Okay, so as a doctor standing in the emergency department, what are the tools available to me? I have my ability to talk, to get history. I have my hands, my vision, my stethoscope. I can do auscultation, percussion of the chest. I can do a visualization of the chest by inspecting. And then after that, I have a chest x-ray. I can do an electrocardiogram. I have lab tests like cardiac biomarkers. I can check a pro-BNP to see if the patient has congestive heart failure. I can do D-dimers to see whether or not this would help me discern pulmonary embolism diagnosis. I can do blood gases and see exactly how much hypoxemia the patient has. Maybe the patient has carbon monoxide poisoning. Blood gases will show you that, not the pulse oximetry. I can do a CAT scan of the chest with angiography to see if we have PE. I can do a VQ scanning, although CAT scan now is the preferred test for pulmonary embolism. I can do a peak flow. I can ask the patient to take a peak flow and see if there is an airway problem, or maybe a bedside handheld spirometer. I can measure the negative inspiratory force. So all these are available tools to me. But again, history and physical is the most important. At the time you're making the diagnosis and using all these tools, you should also be ready to intervene. Intervening meaning you need to prepare IVs, you have to be able to resuscitate the patient, and if you go back to the ABC, A number one is airway. You got to make sure the airway is open and it can conduct air into the lungs. Number two is breathing. You got to make sure the patient has the capacity to breathe, the muscles and everything else that goes with it. Respiratory center being awake, the muscles being strong, doesn't have any broken ribs or anything like that. So breathing, number two. C, obviously, is circulation. That's why we have the IV hanging in there, because hypotension is going to continue to give you respiratory problems, even though the respiratory system might not have the problem, but the other tissues might. So we have intervening by giving the patient oxygen. That's simple enough, and that is like a reflex. It's not even a brainer. You give the patient oxygen if they are not able to breathe. That's number one. Even people on the street can do that, or in the plane or in the airport or anything. Number two, you need to get your tray ready if the patient will need intubation. You don't have to rush to intubation if you can use some non-invasive positive pressure ventilation like a BiPAP, like at the bottom of the screen. Patient using that, especially if the patient has COPD or something that can help overcome with the BiPAP positive pressure, like pulmonary edema, for example. BiPAP is great for pulmonary edema. But if these measures fail, you need to move into intubation, and you should have your kit ready, and obviously expertise as well. That's a bedside ultrasound, and that's a great tool if you have it, because diseases like cardiac tamponade and pericardial effusion can easily be diagnosed with that modality. Okay, now if you go into intubation, you need to know what kind of airway you're going to be dealing with. And on the top of the screen, that's called papillary score. And you look into the patient, you ask the patient to open his mouth and say, was sticking his tongue out. And then you look, if you're able to see a good view of uvula and beyond, then this is stage one. If you see like half of it, that's stage two. If you don't see the uvula, but the space still okay, that's 3. And 4, you don't see anything. You're not seeing the airway at all. And that's the most difficult. Obviously, 3 and 4 are more difficult than 1 and 2, and they need an expert who had done intubation previously with confidence. Okay, so you are doing an airway exam to make sure that you will be able to get the airway, especially when you do like rapid sequence intubation, which is very popular now in the emergency rooms. When the patient is agitated, it is kind of hard to relax the patient enough and ask the patient to cooperate. There is nothing worse than feeling unable to breathe. So the patient is usually agitated, the patient is fighting. It is not an easy thing to open his mouth, force it out, and get the tongue out of the way and find the airways. So a lot of times we use induction anesthesia and also paralytic agents. The common things to use are succinylcholine, etomidate, to paralyze the patient and induce anesthesia. But some people also can use other neuromuscular blockades. We very quickly look for any reversible cause that we can deal with. Foreign body in the airway, you can clean it out. Any secretions, you can suction them out. A chest tube put in for pneumothorax. antibiotic early treatment for pneumonias, stuff like that. Tamponade obviously has to be diagnosed with an echocardiogram and pericardiocentesis. Tension pneumothorax is a life-threatening thing. Chest tube, if you don't have a chest tube kit, you can just put in a needle in the second intercostal space on the side of the pneumothorax. Simple thing, you put it in, and usually we attach it to a syringe with some liquid. You see the bubbles. Once you see the bubbles, at least you're releasing some of that tension, and you're changing a tension pneumothorax into a regular normal pneumothorax until you get your kit, and then you put in a chest tube. We talked about pericardial tamponade and stuff like that. Okay, so to summarize for you, you're standing in the emergency department, someone comes in with a life-threatening problem, either lung or heart. Just remember, in the heart, it's either infarction because of ischemia, simply heart attack. Number two, the patient went into arrhythmia and the heart is not pumping, or the heart is being choked with a pericardial effusion. So think about these three things that can make your heart fail acutely. Try to diagnose them and deal with them as emergently as possible. Now, what could happen in the lung or respiratory system in general that can threaten your life? Something that blocks your airway. Angioedema, foreign body, something swelling, big tongue, stuff like that, anaphylaxis, all these things you need to deal with. Number two, something in the lower airway, COPD, asthma, or foreign body, is something blocking the airway. Down in the parenchyma and the pleura, we have the pneumothorax, we have the pulmonary embolism. So my job as an emergency room doctor, first encounter, is to make sure the patient is oxygenating. Okay, that's number one. That there is enough oxygen going to the tissues. Number two, I need to make sure that there is an airway. Again, going back to ABC. First thing in resuscitation is ABC. So A is airways. If there's anything blocking the airway, you clear it. You make sure that you have an airway. The natural airway is not helping you because of an obstruction or something, you bypass that natural airway by putting an artificial airway, either with an ET tube or with a surgical airway by doing Craig thyroidotomy. Then, if the respiratory system is not able to sustain breathing because of whatever problem you have in the lungs are failing, chest wall is failing, ribs are broken, muscles are weak, diaphragm is not working, abdomen is big, there's pressure on the chest, whatever the cause might be. If the respiratory system is not able to maintain that job, then you do it for them. You begin an artificial respirator. So you put the patient on artificial breathing, ventilator support. Then, now you stabilize your patient. You make sure there is oxygen, there's airway, there is support. And then you start thinking deeper about what could be going on. And then you have maybe a little bit more time to diagnose and to treat and manage. Now you initiate your treatment. Now, some of the things or some of the mistakes we as doctors can fall into in dealing with patients with acute dyspnea. Number one, not getting the airway in a timely fashion. Something is blocking the airway and you don't recognize it. There's a foreign body, there is a plug, there is blood in the airway, something that is blocking the airway, acute bronchospasm. You have to deal with these problems. You have to get the airway working. Number two, failure to recognize that your patient who is sitting in the emergency room huffing and puffing and agitated and becoming cyanosed is about to go into complete respiratory failure, especially signs like use of accessory muscles, paradoxical breathing. These things are ominous signs. They tell you that the patient is about to give up. He's about tired. The diaphragm is not working anymore. He's using all the muscles he could, but he will tire out. And if you do a blood gas and the patient starts with hypocapnia and then becomes normocapnic and then becomes hypercapnic, what does that mean? It means he's not able to ventilate anymore. Carbon dioxide keeps going up. So the patient is getting tired. Failure to recognize that and then come back when they only announce the code blue, and the patient is far gone and you probably can't bring him back. So you have to be able to recognize these signs before the patient develops full-blown respiratory failure. Now, obviously, you don't rely on one single method or one single finding. You have to keep your mind open for other possibilities and differential diagnosis. Failure to monitor the patient clinical course. I mean, patient came in with asthma, I gave him a bronchodilator, and then I left. I went to see some other patients, and then an hour later, the patient is dead. What happened? Well, you didn't follow up. And not every patient who gets a bronchodilator is going to respond. Patient can have some improvement and then go back with rebound bronchospasm. The bronchodilator might not work. You have to give one after one after one. The patient might have another problem that you have not diagnosed yet. So close monitoring until you make sure the patient is well diagnosed and well managed. Failure to recognize non-pulmonary disease. We said that the breathing trouble doesn't always mean something is wrong in the respiratory system alone. It could be a hematologic problem. A patient who's bleeding out is going to be tachypneic, not because his lungs are bad, but because his hemoglobin had dropped by like 50%. And then everybody has to compensate for that, including the heart and the lungs. So if you don't realize the patient could be actively bleeding into his GI tract, becoming tachycardic, tachypneic, and become impaled because he's losing blood. And you might think, I listen to his lungs and lungs are clear. He doesn't have any crackles, he doesn't, air sounds are good. So we're fine. His airway is open, he's moving air. So what? His oxygen is good. But the patient is working hard. There's going to be a reason. So you have to recognize the non-pulmonary causes outside the respiratory system that could be making your respiratory system work extra hard. Acidosis, diabetic ketoacidosis, anything. Also, allowing patients with a tenuous respiratory status to leave the ED. The patient wants to leave the emergency room. You have to be very careful with that because patients can deteriorate. And one thing to remember also, when we do pulmonary function tests, we have something called provocation test or methacholine challenge test. Patients sometimes don't show signs of asthma on pulmonary function test. We try to provoke the bronchospasm by making the patient inhale methacholine. Problem is, they can develop bronchospasm from the methacholine, and we're ready to do with that. But the problem is that they can develop that as a delayed response. So they can go home, and after a few hours, they develop bronchospasm. So you have to be warning patients, and patients need to know what to do if that develops. So discharging patient, letting patient go out of the ED has to be with full instructions as well and proper follow-up. Now, discharging patient with inadequate follow-up or unclear instructions, that's the same thing. Whether you're discharging the patient to the floor without communicating with the team properly to tell them what to look for, what to follow up on the tests that you've ordered, or the things that concerns you might have, a diagnostic workup that you might have initiated for this patient to be followed. So these are some pitfalls in the management. I hope this talk would make you more confident dealing with the problem with dyspnea or shortness of breath in general. And remember, it's all common sense. You just need to think about your pathophysiology. What is it? How does this work? What are the systems involved? And you know that the respiratory system brings the oxygen down to the alveoli, and then it has to diffuse across these membranes in the parenchyma with good VQ matching and good diffusion capacity to meet the hemoglobin in the blood. Hemoglobin has to be good, has to be adequate. So if you're anemic, that's a problem. If you had methemoglobinemia, that's a problem. You have sickle cell disease, that's a problem. All these are problems with the blood, not the respiratory system. But it can give you tachypnea and respiratory distress. Now, transporting the oxygen downstream to the cells, if the cells are intoxicated with carbon monoxide, with cyanide, or sepsis, all these things will make your tissue unhealthy, unable to uptake the oxygen and utilize it properly. And that also can put extra burden on the respiratory system, and that will give you tachypnea. So you need to be able to think about all the other systems involved, including cardiovascular, blood, and tissue, because all these four systems together, respiratory, cardiac, blood transporting, and then tissue uptaking, all of them are part of the respiratory process, which aims to oxygenate down to your mitochondria, because this is where our metabolism takes place. Failure of any of those steps is going to give you the symptoms and the manifestations of dyspnea. So I hope you can very quickly now, with confidence, approach the patient emergency department. Your eyes are on the airways, making sure there is air moving. Your stethoscope is on the patient's chest. Your hands are touching. You're looking for things like pneumothorax. You're looking for things like pulmonary embolism. You're looking for things like heart problems, like arrhythmias, like tamponade, JVDs, congestive heart failure, all these things. And while you're doing that, you're also preparing how you're going to deal with that patient. You're ordering your chest X-ray, your CT angiography, your bedside echocardiogram, your blood tests, your blood gases, and at the same time, you're getting ready for intubation, you're getting your trays, you're checking the airway, making sure you'll be able to intubate easily without problems. You're asking about intubation history in the past, whether it was easy, difficult. You're calling your expert, you're calling your colleague to stand by your side if you're not confident enough to intubate safely. So all these things are happening at the same time. And I hope with that little summary that I've helped you, at least to an extent, to digest all the information and process them all at the same time. I know it sounds challenging in the beginning, but once you've done it over and over and over again, you gain more confidence, and you will actually enjoy it. Thank you so much.